Yeah. All right. Well, welcome everyone. I'm Professor Mulier from anesthesiologist from Bruges, and it's a really pleasure for me to start this webinar organized by M. Dolores on heart rate variability. Nacho normally is our host and would start off, but he is not getting online to speak yet, but he will come in later on. We have three speakers for this evening, myself, Christian Aragon, and Rafa Badanes, and we three will cover the aspect of using heart rate variability on the ICU and certainly in the case of COVID-19 pneumonia patients where it might have a new indication and a new role. I start off with the aspect of what is heart rate variability, what can we measure with it, how does it work, what's its place on the ICU, and just letting up what it is using heart rate variability with COVID-19 patients. COVID-19 pneumonia is not a typical ARDS, but it's an inflammatory, not due to interstitial disease or airway disease. It means the compliance of the lungs remains normal. And what we see is that these pulmonary microthrombi are likely secondary to thromboinflammation. There's a cytokine storm with increasing ferritin, cronus reactive protein, interleukin-6, and decreasing fibrinogen. And the result is a severe hypoxemia with normal respiratory mechanics and normal compliance, suggesting also pulmonary perfusion problems. And so what we have noted is that the ventilation perfusion is mismatched dramatically, even in the patients not intubated or ventilated yet. The severe COVID-19 pneumonia reflects actually a pulmonary vaso-occlusive disease, and there is an absence of hypoxic pulmonary vasoconstrictions requiring most of the time prone position rather than real positive pressure ventilation. With positive pressure ventilation, we even get worse. Ideal would be to use negative pressure ventilation, but this is hardly available on our ICUs to use today. If we look to the radiographic pictures of how it happens, initially we see only this glass opaque appearance on the first day. We get on the following week, we get these crazy paving patterns, and later on it becomes parenchymal bands. So this is here after 2 weeks. We see parenchymal bands absorb in stages. This is a real vascular disease, and therefore the compliance of the lungs remains quite long normal. It's a vascular disease caused by an over-inflammatory reaction. The patients with a pro-inflammatory state, would they develop a more severe COVID-19 pneumonia? There was a little bit of discussion about, as we see, there were the elderly patients getting severe pneumonia, but also younger patients, most of the time males with obesity. And the big question came up, why are these males with obesity more prone to get a severe pneumonia requesting ventilation at the ICU? Okay, if we look, what happened is that the male patients frequently have a metabolic syndrome, impaired metabolic health. And it are just the comorbidities, hypertension, diabetes, and cardiovascular diseases that are associated with more severe courses of COVID-19 obesity. So obesity itself is not a real problem. It is more the comorbidities, actually the metabolic syndrome. And what are the patients who having a metabolic syndrome? Well, the metabolic syndrome is typically there with the patient having a lot of visceral fat. The visceral fat actually is the place where, and if we look at it, it's where the COVID-19 infection will stimulate a larger production of leptin. If you look here to the graph on red are the patients getting severe SARS-CoV pneumonia. And as you can see, we get rising levels of leptin level. The control, patients with severe infection but non-COVID, do not have an increase of the leptin levels. The BMI is not a very good indication. So the patients with a higher BMI, visceral fat, they have higher leptins, and this leptin stimulates also an inflammatory reaction in the lungs, reversing also back again. So it's a stimulation in two directions. How can we find the patients with a lot of intravisceral fat, or that these are the males frequently? And we can look to CT scans comparing the amount of visceral fat. But what we found here out was that the waist height ratio is a very good parameter for that. As you can see here, the visceral fat is increasing with increasing BMI, but in males it is more dramatically increasing in value. In this study here, we have been looking to the amount of, this is the visceral fat, this is the total amount of fat. Now, this visceral fat is best reflected, as you can see here, with the waist to the height ratio. So the BMI is not a good parameter to tell if there's a lot of visceral fat. The waist to height ratio is a very good parameter reflecting the visceral fat. So we can conclude that metabolic syndrome, it's a pro-inflammatory disease. You can best measure it by waist to height ratio. And when it is more than 0.7, there's a higher risk to developing metabolic syndrome and a higher risk to developing a severe COVID-19 pneumonia if you are infected. The mechanism, if you get an inflammatory infection, there is a very interesting aspect is that the sympathetic system activates the inflammatory system, and the inflammatory system is also activating the sympathetic system. And so both systems, the sympathetic system and the inflammatory system, are very strongly linked. And that's where we will come in with the heart rate variability as a tool, not only to measure actually the sympathetic tone, but also to measure the inflammatory reaction. Because inflammation like the severe inflammation by the COVID-19 pneumonia, will induce sympathetic reactions, but also sympathetic reactions will induce inflammation. There's a very strong communication between both systems. We can conclude there is inflammatory cytokines activate the sympathetic system, and sympathetic stress releases also inflammatory cytokines. So it's they're working in both directions. Now, the heart rate variability is a way to measure this sympathetic tone, and correctly the parasympathetic tone being the opposite of the sympathetic tone. And what we can see is that assessing the heart rate variability gives a good idea of the complications happening in major abdominal surgery. Also here in thoracic surgical patients, we've seen that the high frequency power of heart rate variability can predict the outcome. So if there's a loss of heart rate variability indicating a loss of parasympathetic tone and more sympathetic tone, there is more danger to develop dramatic complications in these patients. Now, these were all post-operative evaluations. The big question is, what is its value also in inflammatory states on the ICU? I show you a clinical case where we see here a patient having here a measurement of the heart rate variability with the ANI system. And as you can see here, the parasympathetic tonus is quite low initially, being a high sympathetic tone. And we try to block this sympathetic tone by adding bolus of dexmedetomidine and increasing dose. One dose here, another dose, and gradually we see the parasympathetic system getting activating and the sympathetic system getting more and more blocked. And so once we are above the 60, 70 level, we know that we have blocked sufficiently the sympathetic system. So drugs can help in blocking the sympathetic reactions. Okay. There is an analogy between heart rate variability, as we have shown already. Both systems are very strongly linked, and in this study, it is shown that high CRP levels correlates also with low ANI levels. So high CRP levels measured, or even high CRP levels predicted based on the ANI, correlate quite well. So if you have a high inflammatory reactions, we will have a low heart rate variability measured by the ANI monitor. And this opens a whole new way to evaluate the directly on the spot at the bedside what the para and orthosympathetic tonus is, and at the same time what the inflammatory reaction is. And this is one of the first studies. We will come on others too, showing that if we measure different parameters here, these are all different parameters of heart rate variability. Here in patients with COVID-19 pneumonia, but survivors, here non-surviving. And as you can see, some of these heart rate variability measurements indicate in the non-survivors a more dramatic inflammatory reaction. And as you can see also, the patients having a sepsis, but a sepsis not from COVID-19, they have here higher values. So the heart rate variability parameters are a way to measure the inflammatory reactions and are a way to measure the severity and the probability of a worse outcome of your COVID-19 pneumonia. How can we measure heart rate variability? So we'll go very shortly over one of the existing tools to do that. If we have an injury, we will get an activation of the sympathetic system initially, later on some activation of the parasympathetic system, but the imbalance between sympathetic and parasympathetic system will be seen. We will get an impact. Sympathetic system will make some inflammatory markers freeing that are further stimulating inflammation and further stimulating the sympathetic system further on. Now, if we go and we measure the electrocardiogram, as we've done here, we can measure the distance from air to air wave, and this is not constant. Due to the respiration, there's a normal variability in the distance beat to beat. Now, based on the impact of the parasympathetic system and on the impact of the orthosympathetic system, this variability will increase or decrease. And so what you can do is measure beat to beat very exactly what the distance is and have the average distance and make then a graph of the variation from the average of the heart rate. And this variation will be large if there's a large variability, will be less if there's less variability. And in this way, we are measuring the impact of para and orthosympathetic system. But to be clear, we have to go a little bit further, because if we now do a Fourier analysis of these variations in heart rate, and the Fourier analysis is telling us how much frequency power is there in the very low frequency, in the low frequency, or in the higher frequency. We are still talking about low frequencies. As you can see here, frequencies here, we say high frequency if we go from 0.1 hertz to 0.4 hertz. We are not looking to the frequencies of the heart rate. We are below that. But so in the high range, the power here is a replica of the amount of the parasympathetic activity, while here at a very low frequency, you're more looking to the ortho and parasympathetic system together. And so to look only to the parasympathetic system, we cut off somewhere at 0.15 hertz. We cut off and look only the amount of power here available in the Fourier transformation of the heart rate variation. So we cut this part off, and then we will look what is the amount of power there and set it out in time. So what you will see here is the graph is the amount of power visible in the higher frequencies between 0.15 and 0.4 hertz. And this amount of power will tell what the amount of the parasympathetic system is. And as we can tell, if the power is strong, we say we have a strong parasympathetic system, and there is a possibility to reduce your sympathetic block. You don't need that much sympathetic block at that moment. Ideal, you're somewhere between 60, 70 or percentage. If you're below that, it means that the parasympathetic system is very, very weak, and yet you have a very strong sympathetic system at that time. You can look to both signals independently, but now for simplicity, we just look to the balance only. And so if you have a strong sympathetic system or weak parasympathetic system, it means that there is too much sympathetic stress or too much inflammation, as both are very linked close together on that system. So I would conclude, and I keep it short so that the message is quite clear. COVID-19 pneumonia is an inflammatory disease. It's not a typical ARDS. So inflammation is the problem. Inflammation causing thrombi causing a dramatic ventilation perfusion problems. A pro-inflammatory state increases severity, so patients with a metabolic syndrome are pro-inflammatory. They will get more severe pneumonia, metabolic syndrome. The inflammatory cytokines activate the sympathetic system, but the sympathetic stress releases also inflammatory cytokines, so they're working in both directions. We can measure parasympathetic stress by heart rate variation, and by that measuring sympathetic stress and also inflammation. So we are measuring not directly, but in an indirect way, the inflammatory reaction too on the bedside immediately. In this way, heart rate variability might allow predictions on the severity of the inflammation, and hopefully also, if we are able to treat and to block also inflammatory reactions, see that the inflammation is blocked, happily also reducing the incidence and severity of COVID-19 pneumonia, but there we need new studies for that.